Good evening, everyone. This is Dr. Garais for MED210 Anatomy Physiology 2, and this is week 4, Wednesday evening, August 26th. What's due today is, of course, all week 3 items, which is task 3, discussion 3, and lesson 3 is due tonight or today. Now, what's going on for next week? Next week, of course, I hope you already RSVP'd if you're coming to campus, and now there'll be instructions on where exactly the exam will take place. But generally, it will take, if you already RSVP'd to come to campus, it will be taking place next Wednesday, midterm, 6 p.m. on the 4th floor, Alexandria campus in Health Lab 1. And it'll of course start at 6 p.m. And it will also start at relatively at the same time, like 6:01 online. And how it will work online is you log in, and there'll be instructions, of course. You log in just like you're logging in to go to class, and then I will, via Zoom, I will transfer you or give you, download or upload, however you want to look at it, the file, and the file will be a Microsoft Word file of your midterm, and then you would have an hour to email me back the answers. Okay, and it's a multiple choice, 50 items, and 1 through 50. And so the only thing I should have is your name, a date, 1 through 50 letters that correspond, and it'll be the same. It'll be the same thing. So first things first, before I'll be teaching this class today a little bit different. I'll be doing it in a way that will highlight pretty much how I make exams, and I hope you were able to start looking at in announcements let's just go to it real quick. Practice midterm here. And if you look at the practice midterm, right, you'll see it's basically, your classic 50 items multiple choice exam. Let's just look at it real quick. And if you look at it, right, it's not complicated whatsoever. It's like A through D or A through E. And if you start looking at it, let's look at even like the first chapter. Doesn't it start matching up with all of the objectives of each task or everything that we do the first day? So let's look at the first week, just of what we kind of went over the first week. Why is this doing this to me? I keep on clicking on the wrong thing. So let's say, for example, I'm studying, right? How do you study? Well, I like doing it like objective based. What's my objective? So if I look here in the first week, what was important during the first week? What did we definitely do? We definitely talked about the skin and the integumentary system. Couple of there's also a video here, the aging process. We may or may not have talked about that, but again, skin, right? Didn't really talk about disorder of the skin. So right off the bat, right, what do you know that has to come out? Well, there's even in even the screenshot of this of the video even gives it away, because it's skin, it's layers. And this is anatomy and physiology class. So what are the two kinds of questions that have to come out? One, it would have to be some sort of identification, anatomy. what are you looking at? And two, physiology, how does it work, right? So let's look at some of the questions. And let's see, another thing that you should also notice is question types. So right off the bat, right, you could see the first three were about layers, okay? Which layers have nerves, which don't? Because where's the fat located in which layer? Where does the arteries and veins go? Well, now then it jumps into a physiology question. Okay, mucus is the first line of defense, right? True or false, right? But where? What system? And of course, we talked about not only skin, we talked about breathing. And so that's, of course, pulmonary. All right, function of cilia, what does it do? Another thing we talked about regarding cilia, we also talked a little bit real quick about why you cough, okay? Now, remember, I could also ask questions about cases because you guys worked all this time and the cases will relate to what's important, okay? And I love clinical spins on things. And remember we talked about skin and like burn victims and things of that matter. What did we talk about? We talked a little bit about dehydration, and the first case was about dehydration, okay? So look at the exam that way. Don't look at it like, oh, this is the question that's going to come out, because it's not going to be like that. There's going to be 50 totally different questions. Well, not totally different, but they're going to be along these lines. Here's another physiology question. Which of the following instructions deals with thermoregulation? First of all, you have to know what thermoregulation means and how does it deal with it, right? Now, another way to also look at it is that, of course, thermoregulation deals with sweat, right? Because you sweat in order to control your temperature. But we also talked about sebaceous glands, and you need to know the function of that as well, all right?
Yeah.
So, kindly mute, and if you got any questions, I'll be checking periodically here in the chat section. So when you look at certain questions like that, like this, which of the following blood cells is responsible for immunity, right? And first of all, you have to know what are the different blood cells and what was the, it goes, we had a whole entire lecture that just focused on white blood cells. But you need to also know, because we did mention, what do platelets do? What do red blood cells do, also known as erythrocytes? And what are clotting cells, also known as thrombocytes? Okay, so remember, there's only really two types of questions in an anatomy and physiology exam. Another way I could do this, the layers, I could just have a picture of the layers and just point to it. Oh, look at here. Remember what I said? I could just make you point to things. And that's another way to do it. Ooh, I spelled basophil wrong. Okay. Oh, the different type of white blood cells. We talked about that at length. So you know that's important and that has to come out. So look at the exam, not necessarily on like trying to memorize the question. Look at it as, how did I take something that's important and how did I ask it? And what did I find him? What did your professor find that's important? So with knowing that, let's now jump into week 4 items. And remember, for the exam, it's everything is from week 1 through week 4. So it's all the stuff we talked about, including today. So let's look at what we're looking at this week. What we're looking at this week is excretion, or the ability of how human beings make urine. So we now know a little bit of the property of urine. We have to know the structure and function of how urine starts in our kidneys and how it ends up in the toilet. And while we're doing that, right, that's the physiology, like how do we make urine? And lastly, what are all the structures and functions of the kidney? So right off the bat, you know that could I get a picture of the kidney or one of the pictures here, maybe from your textbook, maybe from this video, and then make you point. Physiology, we have to talk about the endocrine function. And the big thing that we're going to be talking about in urinary function is the renin, aldosterone, angiotensin system. It is the way our kidneys regulate blood pressure and water and fluid intake, and also excretion to control blood pressure. And it's amazingly simple yet amazingly complex. And again, back to this video. These videos are nice and all, but I'll show you a even simpler way to look at it. So let's look at, of course, if you see a urinary physiology lab, we're not going to do this lab, but what's in it? It has lovely, lovely notes, which are important. And of course, all of our systems want to bring balance to our body, also known as homeostasis. Homeo means the same, stasis means to stand in one place, if you recall your medical terminology. And the urinary system is no different. So let us look at all the players in the urinary system. And one way we could look at it is just look at it from the big picture. So could I easily pick a drawing like one that we just pretty much randomly found here? Why is it doing that? All right. Let's pick, I just want to see the picture. Okay. You know what? So when I'm looking at the urinary system as a whole, these are the parts. I have two kidneys. I have the right one and the left one. And remember, you have to look at it that way because it's in perspective. The right one you'll see is a little bit lower than the left one because of the size of your liver. Then you have ureters, which are these little tubes. And there's, of course, two of them. Into this temporary muscular storage called your urinary bladder. And from your urinary bladder, you have your urethra, which leads the urine out into the toilet. It has not one, but two sphincters or circular sets of muscles in order to help you hold in your urine. And remember, I stated that the urinary bladder is a temporary holding place. So you really shouldn't be trying to hold in urine because it's going to have some adverse effects. And of course, you can see here, not one, but two sphincters. Can I easily take a picture like this, erase all of these arrows, and just put A, B, C, D, E, F, G, and ask you, can you identify in this? And it goes in this diagram, the right kidney, left kidney, and of course, remember your bearing. You're always looking at the picture as if you're looking at your patient. So this is your right kidney, this is your left, this is your right ureter, this is your left ureter, and of course a single urinary bladder and a single urethra. And I don't know who named this, it's too close, but it is what it is. Ureter, urethra. Okay. Now another difference is the urethra in our female patient is much smaller and has a close proximity to the anus, so it has a greater predisposition for urinary tract infection. Urethra in a male, of course, is longer, and the distance between the urethral orifice or the urethral opening in the male is significantly further away from the anus, so it won't be as predisposed. And remember the function, one of the functions, we're going to talk about more functions of the kidney in a moment, because the kidney's the star, right? So if you have a urinary tract infection, so you could have ureteritis, you could have cystitis, right? If you recall your medical terminology, that's in urinary tract infection at the level of your urinary bladder, or urethritis, which is here as well. Now, UTI on the scale of things isn't horrible. Its side effects are not debilitating, but if allowed a chronic UTI to go unchecked, it can ascend and easily become a kidney problem. And if it becomes a kidney problem, that's a very, very serious problem. And we're going to talk about the functions of the kidney momentarily, because if you have a kidney problem, it's not only going to affect the production of urine, but also the other physiological functions of the kidney, which again, I'm going to talk about momentarily. Now, the specialty that deals with kidneys, and there's also specialties that deal with the urinary bladder as well. So for the lower parts, of course, the urologist would be the experts of, kidney, ureter, the entire thing. But urology is typically geared for male patients, and gynecology is geared for our female patients. And I think I'm getting into a medical terminology lecture more than a anatomy lecture. So let's stay on track. So now that you know all the players, let's go. And here, there's these nice notes here, but I want to get to, and we're going to go back to this. I want to get to in chapter 25.8 in your ebook. So let's go here. And why do I keep on touching that? Go in your course textbook, OpenStax, of course. Hit up my table of contents and chapter 25. And they also have physical characteristics. And remember, gross anatomy. I'm going to go back to the characteristics of urine in a minute. The gross anatomy simply means the things that we can see. So we've already now identified the big picture: ureters, urinary bladder, right? We now talked about differences between male and female, and the two main differences is the length of the urethra. And if you could see here, the urethral tube here for your female patient, let's make this a little bit larger, is from here to here, right? And its proximity to the anal orifice here, also known as your anus, okay? But in the male, right, tubing is here, and your urethra is here, and again, since it's since the urethra is then along with the anatomy and physiology of the male penis and also reproductive structures, that's why any urinary tract issues most likely will be dealt with urology here. And for female patients, it would be dealt with the Department of Gynecology. Okay, so we now know the big picture and now know the difference between male and female. let us look at, I wanted to get to, all right, might as well, I guess I'll have to start talking about these things. Well, the ureter is also covered in not only epithelia or like skin, it's got its own little sublayer of muscles, because along with not only gravity, but urine will um, get transported from your kidneys to your urinary bladder via your ureters in a peristaltic fashion, just like the way your food goes down your esophagus. And if you recall, peristalsis is the coordinated action of a tubular muscle to push your food down your food tube, your esophagus. Well, in the same way, your ureters do that with urine from your kidneys and down into your urinary bladder. And as you can see here, your urinary bladder there's partial covering of your peritoneum, and that's the covering of your abdominal contents. And you'll see inside here what is inside really a urinary bladder is. It is a muscle, and it's a muscle that can expand and shrink because it has transitional epithelium in here. So just like a balloon, it can be as small as about the size of a golf ball in your typical 70-kilogram male, and it can hold, in a 70-kilogram male, it can hold as much as about 2 liters. So it goes. So you could see how this thing is built for expansion. But again, I have to reiterate that it's not a good idea to hold your urine for an extended period of time. Now, why? Urine is essentially a waste product, right? And water. And it was waste product in the form of nitrogens. And we're going to show that formula in a moment. Now, urine is sterile. But what happens with urine with things in it, or what happens with even water with nothing in it if you just leave it out, especially in a dark place that's warm around 98.6 degrees Fahrenheit or 37 degrees Celsius, which is our body temperature? This turns into a lovely incubator for bacteria. Okay, that's why it is stated that the urinary bladder is a temporary. And here, what they're not showing here, you got to use your imagination a little bit, that it's a circular ring if you think about it 3D. And of course, you have another one here, and you could see the bands run around here circular. You have to, this is like a cross section, but think of it as like a shrinking donut. And that's what you have, both internal and external urethral sphincters. But when you got to go, because these two will eventually give way. And this, since it's one big muscle, will start to spasm, because ultimately, do you have any real control over your bladder muscles? No, you do not. You have control over your abdominal muscles, which can also push down on this if you increase your intra-abdominal pressure by performing like, you're bearing down, or performing like what we call a Valsalva, which is bearing down and forcing pressure from your abdominal cavity onto your pelvic cavity here. So remember, temporary, and that's also the reason why these muscles, they're visceral muscles, they're smooth muscles. You can't really control them. Okay, you can control them, the external urethral sphincter, you could control it to an extent, but ultimately you're going to have to urinate, and it's going to have, and the pressure and the fact that it is waste, it has to be removed, right? So if your patient, for whatever reason, has an obstruction or maybe a neurologic issue which forces these urethral sphincters shut, that's a problem. But that's easy. We use this very large bore needle, and we do what we call suprapubic tap. I could stick a needle through here, I could tap it, and then empty it that way. But that's never a fun or pleasant experience for your patient. So let us now go to, I have this. Let us now go to the next thing. Micturition, or micturition, potato, or just also known as urination or voiding. Like I stated, it goes, it's a reflex. Now, what does reflex mean? Reflex means is that it's something that does not require thinking. It doesn't require the brain, okay? We don't have any real direct control over the other sphincters and, of course, the urinary bladder. So when you got to go, you got to go. Now, as I mentioned earlier, then what happens to the external sphincter when there's a neurologic, or maybe the patient's either very young, right? They don't have neurologic control yet, or the patient's very, very old and has lost neurologic control. And that will result in incontinence, okay? Another thing that will also is common that will result as in incontinence is that if our patient is female and had a lot of children, the pelvic floor gets all loosened up after several pregnancies, and that will also loosen up the sphincters as well. And that's why we have many patients who have pressure or stress incontinence secondary to multiple pregnancies. And many patients who suffer from that is they sneeze or they cough or even laugh, they wet themselves a little bit. And it's because the pelvic floor here, and there's ways that we can tighten all this up, but that's for your either your obstetrics and gynecology class or your surgical class. Now, all of this is controlled, of course, by your sacral micturition center. That means you have nerves here around your sacrum. So what happens if all these nerves are damaged, you broke your back, or you get a saddle injury? Saddle injuries are like, my last patient had a saddle injury. He was riding his motorcycle and he jumped a large, I don't know, like a highway divider, and something like 15 feet, and then he landed right on his pelvis. Of course, fractured his sacrum, but the S2, S3, and S4 nerves were damaged, and now he was no longer control of anything down here, and that includes erections. It's kind of sad. He was kind of young. Let's look at the ureters. You could see that there's a smooth muscle layer. So that's a nice question. Can you control the urine going down into your urinary bladder? No. Can you control your urinary bladder directly? No, because all of that is smooth muscle. And when you void, when you pee, you're actually just letting go of your external urinary your external sphincter, and you're also bearing down, which also increases your intra-abdominal pressure, and then from your intra-abdominal pressure, then it pushes everything down. So blood vessels, you could see how important the kidneys are. That remember I just mentioned the peritoneum. The peritoneum, if you recall, was that covering of your abdominal cavity of all your abdominal contents. And if you recall your Anatomy and Physiology 1, when we dissected the pig, the kidneys were located behind the behind the peritoneum, hence its retroperitoneal location. And you could also see here, whoever created us perfect and had not 10, but 12 ribs, so that it would cover a decent portion of your dorsal anatomy, so it'll also protect your kidneys as well. Okay. So let's look at structures here. Now, doesn't this look like a beautiful picture? And this is an anatomy class. Can you take this and put it in Microsoft Paint and then just erase all of these? And now you have A, B, C, D, E, F, G. Can you do that and practice that for next week? Could that potentially come out? Sure. Yeah. So let's look at all the important parts. So the first thing we have to look at when we're looking at the kidney is that if you see here, and they kind of, in this diagram, they kind of really draw it out that this outside, there's an outside portion, right? And that's called your cortex. And then you have this inside portion here, which the only way, best way to describe it is a whole series of funnels. Okay. Now we already know that the main function of the kidney is the creation of urine, but how do we create urine? Well, this is what happens. Okay. The renal artery is here. You got the renal vein, and of course, renal nerve, because wherever there's an artery and vein, there's got to be a nerve. And then you have, of course, here, this big tube that's connected to your medullary structures. This is medulla. And this is your ureter. So the blood goes into the renal artery, and it goes in dirty. And what do I mean by dirty? It's got way too much nitrogens in it in the form of ammonia. Now, we know that we need carbons, hydrogens, and oxygens. That's in the form of carbohydrates. But we also need proteins, carbons, hydrogens, oxygens, and nitrogens. Now, we don't need that many proteins. We need a decent amount, but the extra nitrogens have to be removed from the blood. And the way they do it is through this kidney. So it gets filtered out here in the cortex, also known as the cortical region of the kidney, the outer edge of the kidney. And that's where we're going to talk about, that's the location of these millions of microscopic structures called the nephron. The nephron is called the functional unit of the kidney. And we're going to table that and put that aside for a minute. Just know that the nephron is going to do its job and it's going to make urine. So in this cortical area, your cortex, all along the edge of the kidney, right? That's going to make urine. And then the urine is going to fall into these funnels. And the first funnel that it falls into is this large structure here called your renal pyramid. You got to use your imagination a little bit, where you got to look at it like 3D. And if you look at like a triangle in 3 dimensions, it looks like a pyramid, like an upside down pyramid. Then it's going to go through a smaller funnel called the minor calyx. Then it's going to go through a larger funnel called the major calyx into this big area here called your renal pelvis. And from there, all of that urine gets collected and then falls into the ureter. And then the ureter will then perform peristalsis and then bring it down. Now you'll see the kidney has a classic shape where it's like indented right here. This indentation is called your hilum. And the hilum is really important because that's where all these really important structures that go in and out of the kidney lie. So this looks like a beautiful all of the above question. Which of the following are structures in the hilum? And we already know what goes in and out of our kidney. First, blood's got to go in and blood's got to go out. So that's renal artery, renal vein, right? And when it goes out, renal vein, it should be, in theory, clean, right? And back into circulation. There's, of course, a renal nerve, and of course, your ureter comes out of there. So when we're doing dissection, probably next week, right? When we're opening up the big kidney, what are we going to be looking for when we cut the kidney in half? Well, I'm going to be looking for these structures. You probably won't be able to see the renal nerve because they're very, very thin, but you'll definitely see a renal artery and renal vein and a ureter. What's another question I could ask? What's in these tubes? What's in the ureter? Of course, urine. Okay. What's in the renal artery? Dirt, quote unquote, dirty blood, right? Nitrogenous blood filled with nitrogenous waste. Now, if this nitrogenous waste doesn't get filtered and doesn't go down in the form of urine, then if that nitrogen stays in our blood, you'll get something called azotemia. That's not good, and that's just like sepsis. It's bad news. And remember, too much of anything, whether it's good or bad, in the system is no good, because homeostasis wants to be in the middle at all times. And this is how we get rid of those extra nitrogens. So what kind of questions could I ask? I could ask, what region? I could point at this region and you'll tell me, oh, that's the cortex, also known as the cortical region. If I point here at the pyramids and all these other funnels, your minor and major calyces, that's plural for calyx, and your renal pelvis, that'll be all what? Medullary. So if you hear that my patient has medullary cancer of the kidney, where is the cancer? It's here. If my patient has a cortical issue in my kidneys, right, where's the problem? All along the edge in the cortex. Okay, so this is a wonderful picture, and it outlines the internal anatomy of your kidney. And if you look at it, the way we look at it, we're looking at the left kidney. And remember, and see these little caps on top of both kidneys? Those are your adrenal glands that we talked about in Anatomy and Physiology 1. And we're going to also be talking about adrenal glands shortly again. Remember we talked about cortisol? Well, that's where that comes from. Up here, your adrenal glands. Adrenal, ad means above. Renal means, of course, kidney. All righty. So let's shrink it down. Blood vessels, I guess, and you don't have to know them at this level yet, but eventually you will. Oh, I forgot to mention, look at this again. I forgot to mention what's holding up all these things. Let's see if they pointed it here. No, they didn't. Well, if you look here, okay, these are called columns. And the columns, can you see, like the columns, you got to use your imagination a little bit. This section of renal tissue holds up the pyramids, right? And you could see because, and there will be, each little section is called a lobe. And hence, there are interlobar blood vessels. So there'll be blood vessels in between here, and all in between here as well. Okay, that was the one little part that and then of course, when they get smaller and smaller, they become arcuate blood vessels, and they arc. That's how I remember it, right? So interlobar, it's located in between the lobes or within the columns. And you have your arcuate blood vessels here as well. And remember, they're getting smaller and smaller and smaller until, let's go down to our next picture, they get to the level of this size, which are, they have arterioles and capillaries. So let's look at this thing. And this structure here is a diagram of, remember I said about the nephron, all the microscopic structures that are, there's several million of them in both of your kidneys. Now let's get to the nitty gritty of what this is. So we already know that when the renal artery comes in through the hilum in your kidney, it's dirty. So it's got a whole bunch of not only nitrogenous waste in the form of ammonia, it also has extra things in it. Because remember, like we're all about homeostasis. We're all about being in the middle. So anything that's too much in our system, in our blood, is considered waste. So we have to get rid of it. So if there's too much sugar in my urine, great, I'm giving away the answer. If there's too much sugar in my blood, what's going to eventually end up in the urine? Too much sugar, right? If there's too much salt in my blood, what's going to end up in the urine? Because blood filters through the kidneys. So anything extra, like proteins, urine, or if this thing's broken, it's all going to end up in the toilet. Okay, and that is also the reason why if you're in my lab, my medical laboratory class, we talk about how many diagnostic series have to coincide with both blood and urine. A classic example is a pregnancy test. It's not enough that you peed on the stick and the stick said you're positive. You have to come in and see the gynecologist, because I have to get blood work and I have to see the same level of HCG, human chorionic gonadotropin, in my blood as I see in the urine. Okay, so blood and urine, even though we talk about them in two entirely different states, they're, as you can see, they're inherently connected. So let's look at this whole entire thing is called nephron. And the nephron is the functional unit of your kidney. And again, it's in the cortex region of your kidney, the outer layer, and there's millions of them. So the first thing it does is the interlobar arteries, they get really, really small until they become arterioles. And at the level of, it starts also becoming to the level of capillaries. So that the tubing in here, this thing is called your glomerulus, right? Surrounded by your Bowman's capsule, also known as your glomerular capsule. So this is the exact location where your kidney is going to filter this blood. So this nephron has three major functions. One is filtration. It's going to filter anything that's extra, and we're going to get it and throw it out into the urine, into this tubing here. Okay, so that's one, filtration. Now, in this tubing here, okay, it goes through the proximal convoluted tubule, or PCT. Then it goes into this big loop called the loop of Henle. Then it goes through the distal convoluted tubule, and then out into your what do you call that? Urinary tubule, into eventually into your what's the word I'm looking for? Pyramids, your renal pyramid. So all during these tubes, there are two other functions that happen. And all throughout during these tubes, you could see that the blood work is still kind of married to the urine here. And it's because this function here, filtration, is not 100%. It sometimes makes mistakes. So whoever built this perfect, with two backup redundancy systems. And the two systems are called reabsorption and secretion. So let's say, for example, I threw out too much glucose, and glucose is now floating through this tube, about to be filtered out and eventually end up in my collecting duct and eventually end up in my urine. But my kidneys sense that, well, wait a minute, I need that. So it will perform the reabsorption function. And the reabsorption function is, oops, I accidentally threw out something important. I want to take it back, reabsorb it. So your blood vessels will take back that glucose that was accidentally thrown out. Now, that's the first backup system. The second backup system to filtration here is your secretion system. Let's say, for example, I threw out some salt, but not a lot. And then the salt is still, the salt is still in these blood vessels. Then I get a signal from my kidneys that, hey, you're retaining too much salt. We got to get rid of more salt. That's called the secretion function. So during these other tubes, right, especially in the distal convoluted tubule, the salt is going to get thrown out. And that's called secretion. So let's review the three major functions of this functional unit of the kidney, the nephron. One, filtration at the level of the glomerulus, surrounded by your Bowman's capsule. And in the other tubes, you have secretion and reabsorption. Reabsorption is when we throw out something that we accidentally threw out and we want to take it back. And secretion is something that we shouldn't have thrown, something we should have thrown out, but now we have the final chance to make sure that we threw it out. Okay. Now, last but not least, throughout all these, is your loop of Henle right here, or loop of the nephron. And Henle is spelled H-E-N-L-E, and there's a video on it. Now, the important part of the loop of Henle is it retains salt and retains water. Here is the major portion of your nephron that regulates water and salt retention. For now, that's all you need to know. But there's a, after you finish your biochemistry and you get into your pathology course, you're going to talk about what they call the countercurrent here. But that's for future reference. For now, what's the worst I could do to you? One, I could ask you to identify. So what's this? That's a glomerulus. What's this? That's your Bowman's capsule. What's this tube? That's the proximal convoluted tubule. What's this long tube right here? That's your loop of Henle. What's this tube here? Distal convoluted tubule. What's this tube here? And that is your collecting duct. And where does the collecting duct go? It goes into your medullary cavities that have your pyramids, minor and major calyxes, and will end up in the renal pelvis into your ureter and into the urine. So there's a blood side and there's a urine side. And it enters through the arterial system and then leaves the through the venous system, and it should leave clean, meaning to say balanced, meaning to say no nitrogenous waste. And if there's an excess of nitrogens or an excess of nitrogenous waste, or if the nephron or kidney isn't doing their job, you will see azotemia, you'll see increased nitrogens, you'll see increased ammonia in the blood as well here. And of course, if you have any kidney problems, what won't you see in the toilet? You won't see urine, okay? Or the urine will be of, it won't be of the proper consistency, okay? So nephron, another beautiful picture. And you could easily do what with this picture? A, B, C, D, E, F, G, okay? The nephrons, the proximal convoluted tubule, what else? Nephron, functional unit of the kidney. Okay, we already talked about that. We already talked about, now capillaries, the only thing you really need to know about capillaries is that they're very thin. Blood and items such as glucose, salts, and fluid can easily go in and out. Now, here's another beautiful picture. As you could see here, your arterioles coming in here, right? And then there's a tuft of capillaries here. This is your glomerulus, and it's surrounded by your Bowman's capsule. And right here are JG cells, or your juxtaglomerular apparatus. Now, what's the best way to talk about it? Remember I just mentioned that your body, your kidney just knows how much sodium, or your kidney knows this and knows that, how it detects certain things. This is one of the ways that that your kidneys detect things. And the JG apparatus, or juxtaglomerular apparatus, and the juxtaglomerular cells, and juxta means right on top of. So it's right on top of the what? the tuft of capillaries here called your glomerulus. Now they kind of sense the composition of urine, blood, and they kind of sense like, what should we keep and what should we what should we throw out. And all throughout this process, there is a measured pressure and a measured rate of how fast all of this should happen. And it's with respect to your blood pressure and your cardiac output. And that's your GFR. That's your glomerular filtration rate. It is one of the ways that we also know how well your kidneys are doing its job, and that's GFR. Now, let us now go into, I don't like that picture. Let's go back. I want to show you guys. Better picture that I got off the internet, that I always use off the internet. Okay, we got a question. Okay, let's look up the RAA system. Now we now already see how urine is directly related to blood pressure, because we already know that blood pressure deals with the amount of fluid you have in your system, in the form, of course, the pressure exerting on blood. So the more fluid you have in your system, the greater blood pressure you'll have. We also know now that the kidneys deal with salt, and the JG cells detect salt, specifically sodium. And now, because that too gets regulated as well in blood pressure. So the kidneys are wonderful sensors for blood pressure and also blood volume. So one of our goals of today was this. I hate you, Pinterest. Why can't I love this picture, but where's the other one? Or maybe I could take this picture. Because this picture is my favorite because it's simple. See if it'll. Nope. I could do it this way. Do it this way. Always more than one way to skin a cat. There you go. So let's look at this. Again, this is one of our goals for today. So you could read the textbook and the notes that go through all of this, but doesn't this look and scream, what do you call it, your concept map? And it looks complicated, but I want you to step back and look at it. Can you see that it's forming parts? Like you got one part here, and then one part here, and then like one part on the end. So instead of memorizing like all these separate things, you memorize them in 3 separate parts, and then you put them all together. So how does your kidney regulate blood pressure? Well, it regulates it through, of course, hormone levels. And hormones, we already know, are chemical messengers that tell our body to go do stuff, okay? And it doesn't happen very quickly, but when it happens, and the reactions to it stay good for quite some time. So if we're thinking about homeostasis, if you recall the last chapter of Anatomy and Physiology 1, if you recall, there's something that has to spark your sensory system, which was your ascending fibers, to tell the brain, hey, something's going on, and then the brain will then have to react through its descending fibers to go effect a change. So you have the detection first. So what do we detect? We have to detect, and in this case, the detection is decrease in blood pressure. And we already know that the decrease in blood pressure could either be due to one or two things: decrease of salts or decrease of blood volume itself. So this is, think of it as just one big thing, okay? Now you need to know, what is the response? So the response, you could see, is like in two sections. Because if I have a decrease in blood pressure, what do I want to eventually do? If I have a decrease in blood pressure that starts all this, I want to bring my blood pressure back up to normal. So the response of all of these things that we're about to talk about will be increase of blood pressure. And we already mentioned that when we talked about the cardiovascular system, that the two ways to increase your blood pressure is either through increased blood volume, right, and or vasoconstriction of the arteries. So you could see this is the beginning. This is the thing that's going to trigger all of this, and this is what we want in the end. So I could ask you, what triggers the RAA system? And you'll tell me decrease in blood pressure. What else would decrease blood pressure? Well, I also have a decrease in blood volume, and I probably low in salt. Okay, so what's my RAA pathway going to do for me? Well, it'll regulate my blood pressure by increasing it through two ways: vasoconstriction of my arteries and increase in blood volume. Doesn't this look like a beautiful both A and B question? Doesn't this look like a beautiful both A and B question related to blood pressure? So that's another, this is also how I make questions, right? So you can kind of see how the questions kind of play out. So let's talk about the sequence. We already know that the JG cells detect sodium. And we know that there's going to be a problem with my sodium and problem with my salts. So the JG cells will release the hormone renin. Renin then gets turned into angiotensin 1, but it needs angiotensinogen. Now, how are you going to remember this? If you look at the word, the hormone angiotensinogen, if you see gen at the end of a hormone, it means it's an inactive trigger, okay? So angiotensinogen is inactive, and in order to be active, it'll lose this gen and become angiotensin. So angiotensinogen is from my liver, and I could see the picture. And remember, a picture is worth 1,000 words. So I'm seeing the liver with this angiotensinogen here, and then the renin, which came from my kidneys, because my JG cells, detected this, right? You can see it's like a story, right? He said this, then she said this, and then this thing happened. And that's a better way to learn something than trying to read it. So I could ask, well, let's just talk about the process first, and then I could show you what kind of questions pop out. So the JG cells increase renin, and the renin will convert angiotensinogen to angiotensin 1. If I have an angiotensin 1, there's got to be an angiotensin 2. So something's got to convert it. Of course, angiotensin converting enzyme, right? ACE. And that's in my lungs, right? And that makes sense because we already know that my blood pressure is related to my blood. My blood is related directly to my heart. My heart has to also deal with my kidneys, right? So, I mean, my kidneys and my lungs. So there, you could see how, even though we talk about all of these things in a vacuum, right? You could see how all of these things are all what? Tied into each other, right? And how each one affects each other. So the JG cells release renin. Renin changes angiotensinogen to angiotensin 1. Angiotensin 1 then turns into angiotensin 2 because of ACE, and ACE is angiotensin converting enzyme. So what's it going to do for us? Well, it's going to, the first part, it's going to lead to vasoconstriction of my arterioles. which will increase my blood pressure. What else would it do? Remember my adrenal cortex? I know that my blood volume also has to deal with salt. So what's going to happen? It's going to signal my adrenal cortex to make aldosterone, hence the term renin, angiotensin, aldosterone system. And then the aldosterone will do what? Increase sodium, increase water reabsorption. And remember, wherever sodium goes, water goes. And what will happen if I keep all my sodium? If my kidneys keep all my sodium, then the blood volume goes up, and then my blood pressure will go up. Now, looking at this, again, in the beginning, it looks crazy complicated. But if you start breaking it down into sections and what the sections lead to, like, for example, you know that this section is the salt section, okay? So that's got to be adrenal cortex. And everyone try this. Now that you've been looking at this for about a minute or two, can you close your eyes and can you see everything? You can kind of see things. You could like, oh, that's the liver was on the left side and the JG cell was like up there, right?
Yeah.
Actually, in my notes, I would put a big J and G right here. And there's a lung on the left side, and that's called, and it had an ACE in it, right? Right? And ACE means angiotensin converting enzyme. So what kind of questions could come out? I could ask you, where does renin come from? Close your eyes. You know it's from, and you wrote the words JG on top of a kidney. So it's JG cells of your kidney. Angiotensinogen, where did it come from? It goes, it came from my liver. And what will it do? It goes, tensinogen. Oh, the gen means it's creating something. Oh, it's creating angiotensin 1. Okay, 1 has to go to 2. And then 1 to 2, I see a lung next to it. So that's what? ACE, right? And I would draw like an ACE or something, or just write the word ACE, ACE, right? So I could ask on exam, what converts angiotensin 1 to angiotensin 2? ACE, angiotensin converting enzyme. I go, what deals with salt retention? What deals with potassium and extracellular fluid? Oh, I remember this little triangle cap. Oh, I know what that is. That's my adrenal gland. And the aldosterone was the last part. Who releases the adrenal? Who releases aldosterone? Oh, my adrenal gland. Oh, and what does it do? I remember all the salts were here. So, it has something to do with my salt. Retention of salt, retention of water, hence increased blood volume. By the way, everything that I just talked about, I just did it with my eyes closed because I'm seeing it. So another trick you can also do is take a couple of times and draw it out yourself.
Mm-hmm.
Did I tell you guys about, I used to cheat a lot in grade school? And I was really good because I have that Filipino handwriting that's very, very small, and I could easily I used to get paid in 8th grade to make crib sheets, right? And then I used to go to Kinko's and then photocopy them and hand them out to people for $5, right? And here's the thing, being a good cheater, one of the things you have to know is I don't have a lot of space on those crib notes, right? So I have to figure out what's important. Well, I know I'm rehashing the story again, but one day I got gum or something on my shoe or whatever, and I couldn't cheat. Guess what? I still passed the exam. Why? I figured out what was important. I wrote it down a couple of times, right? So I passed. Right? And it's also horrible when you have a certain kind of writing. The teacher knows it definitely how many times I got caught. I started getting caught a lot in 6th, 7th, and 8th grade. And then by the time I was in high school, I was like, man, I can't cheat anymore. I keep on getting caught. And in medical, you will get caught, okay? Because if you get into a habit of cheating, it's going to follow you and follow your career. And then it's something called the slippery slope. You're going to cheat more and cheat more and cheat big. And until when it's so big that now you have criminal charges on you.
Yeah.
To this very day, I have a very, very good friend of mine. We graduated medical school together, and he cheated his way through medical school. But he was a good friend of mine, so, I tolerated it, and then he cheated on his boards, and he was kind of proud of it. Well, guess what happened in his second-year residency? He was found falsifying documents, which led to the death of a patient.
Wow.
Yeah, he didn't get the criminal charges, but he had a multi-million-dollar wrongful death suit, which he lost.
Wow.
Fast forward, he's living
And,
his- he can't work anywhere, even as a teacher.
oh my God.
Yep. I think he's Ubering or
In
something, taking
education.
cables or something. And this guy has both a master's degree and an MD, and he's trained in surgery. He lived through 2.5 years of surgical residency to be embarrassed, and his name is Mud in my in my facility, and they look at me like, "You're friends with him?" And I'm like, "Yeah, but you know, how can you be friends with him?" And I got a lot of stuff like that. Like, maybe you cheat too, and I'm like,
What?
man. And he goes, "Hey man," he goes, "If I cheated, would I have scores like this?" And then people would leave me alone. And also, I also know that this is going to save someone's life one day.
Yeah.
Right?
Yeah.
And also, now, do you think now you can explain to your patient on a simpler level that makes more sense? Like, how's this? My patient is taking an ACE inhibitor. Why are you giving me something that coughs so much? Because what's the alternative? Your blood pressure will boil. So a little bit of coughing, you're gonna have to go deal with it. Oh, what's a water pill? Well, because why does it mess up my salts? And why do I have to be in a low salt diet? Oh, because if I give you this water pill, it's gonna throw out all your salts anyway. So you might as well not eat salty foods because it's gonna throw them all out anyway. And you're gonna have to pee like every 15 minutes. So choose low salt diet, or I give you a medication that kicks up your aldosterone, and you pee every 15 minutes, which is gonna be. And explain it to them that way, right? Instead of like, you have to do it, or you know what some of my colleagues do? Oh, it's too complicated for me to explain. Is it really too complicated? No, it isn't. It is
No,
not.
it's not.
You should be able to say this to any person, child.
Kindergartner.
But you could see how all those chapter of those words, you could see how hard it would be to try to interpret it if you didn't have arrows and little boxes, just like so now when you look at it, your concept maps don't look like busy work anymore, does it? It's training you to start looking at text in a different way. And actually, all my protocols, they're in my head like this, but then there's now numbers now. And you could use this, and then especially with like medications and stuff, when I teach pharmacology, I start adding numbers and dosages all around these little arrows because it means something. So can you easily see how I can turn all of this into questions?
Yeah.
Yeah, and how you can probably go home tonight. Well, you are at home. You can actually go and sit and can you figure out every potential question that I can ask from this page in about 10 minutes? And if you could figure out every potential question that I could ask, don't you think that's a better way for preparing instead of sitting there trying to memorize what's in the notes? It kills me when I see the nurses prepare for their NCLEX and their NCLEX prep. When I was at Falls Church, they used to be in the hallway sitting there, Renin, Angiotensin, Angiotensin 1, and they're mumbling to themselves. Number one, that's ramping them up, makes them more nervous.
Yeah.
More nervous. How well is your performance? Instead, how this? Look at the picture. Stare at it. Close your eyes. Stare at it. Drop it. Stare at it. Close your eyes. And then the next thing you know, now you know why I like this picture better than, did you see the other pictures?
Yeah.
Typical, yeah, try memorizing this.
What?
What's that? Right? Or this. Or even this. This one's weirder.
Are some of them even right?
Semi. Right? But they're partial. Or how about this? This is the thing that's in my medical book. It's all words with little arrows, but it doesn't. This is even better. See how this is better? Hey, look what it's gonna do. It's gonna make it smaller. And you can. This one's even just as cooler. This is even cooler, right? Because it's got kidney, this, and then you got this little angiotensin, right? So start looking at it that way. It'll help you in the long run, especially when you're looking at something that's complex. And I can tell you, you'll be looking at complex stuff soon enough. Right now, I'm just warming you up. I have to do that public service announcement. Every midterm, I've got half a dozen calls already from from my former students who are now in nursing program. Dr. Garais, I need tutoring. When's your exam? Monday. I can't help you. You're done. And he goes, did you do what I told you to do? Week 1, week 2, week 3, week 4. No, that's why I'm in trouble now. Well, I'm sorry. They want me to come. 2 students want me to come in Saturday and say, oh, he goes, have you taught nursing 200? I'm like, no, I'm not a nurse. So you can watch this video, which I think is okay, but I like that picture, and I'll even put that picture on, like to add onto announcements.
Dr. Garais, I have a question.
Shoot.
Do you have concept maps like from the other tasks? Like it was just curious if you had any.
Like the ones that I make?
Yeah, or like something that, like I can look a reference back to, like compared to my maps,
Oh, see, here's another thing you could do, which is what a student of mine a couple terms ago did.
Mm-hmm.
But what she found was the concept maps that are online, they're way more complicated than the one than ours are. Ours, I like keeping it simple.
Yeah.
Because you don't need it to know at that level yet.
Yeah.
Because I want you guys to know it at this level first, right? But no, I don't usually keep anything. And you don't want my notes. My notes are very thorough.
So it's pretty much what you have like listed on there. For example, here on this page that we're at right now, like under task, you see 1, 2, and 3. Like if I could just section those out and all in one map.
But now you could see, if you've been following my lecture, urinary system, structure and function, right? You have a circle for kidney. Then kidney will have structure and function. And then in the function, you'll have another arrow that says endocrine regulation of kidney function. And that's exactly how I did my lecture, isn't it?
Yeah.
So when I do my lecture, when you listen to the recording, another student of mine said, hey, I just listened to your recording, and every time you talk about the next thing, I make another bubble. And I'm like, yeah, that's pretty much what a concept map is. And that's actually, like, what you guys don't see is it may seem off the cuff, but I've been teaching this for a while. I actually plan stuff. Sometimes I get a little lost, especially if I start talking about like professional stories, or even not so professional stories. Which I'm now that we're in this atmosphere of online learning, I am much better. Those of you who had me on the ground know that. Oh, well, I'll start going off. I'll start.
Yeah,
going
I know you. I've been in your class
like,
before.
You're like, hey, when's this guy gonna come back? And sometimes we don't, and and then I have to do videos and whatnot. So so when you look at here, look at how we did it. Look how much harder it is. Imagine if you had to read this.
Have to read all of it.
What's that? That's not fun. Now, as I promised, now that you know what urine is, what's basic urinalysis, right? Or U/A? Well, they come in 3 parts. You have your physical characteristics of urine, microscopic characteristics, and of course, chemical analyses. Now, the physical parts are easy. Of course, volume, clarity, and smell. Now, urine should be clear, okay? Because remember I told you, all it is water and some nitrogenous waste and a little bit of food coloring in the form of some various chemicals that we'll talk about in clinical classes. But that's all essentially is. And volume is important. And that's why you as future nurses, please, if I tell you to go get volume at 2 o'clock, 3 o'clock in the morning, it's important. Don't wait till 6 and then, get me one big volume at 6 a.m. By that time, it might be too late. And a lot of times, and nurses aren't the only ones who do it. Doctors, medical technicians, they're like, yeah, I'll get it later, thinking it's just a number and it's just urine in a bag. No, it isn't. Now it's really important that I got to monitor that because it relates to my kidneys, it relates to my liver, it relates to my lungs. There's a whole bunch of stuff now that are pending on what you've seen. What especially some of the senior staff, they deem it as like scut work. You'll hear that term. SCUT means some common unimportant task. And they call you, unfortunately, you know, when you're neophyte nurses or neophyte clinicians, they'll call you a SCUT monkey. Please don't take it. It's just how they call you. They do that to doctors, technicians, but if they call you SCUT or, you know, a SCUT monkey, you know, don't call HR and say, I'm being harassed. It's just how it is, right? And nowadays they probably won't call you, but during my day, they called me far worse. But they'll go, hey, SCUT. And I'm like, yes, yes, sir, yes, ma'am. Right? And one of those things are, hey, did you do urinary volumes for the floor? And you go, I did it an hour ago. Do it again. Come on, Scott, I need it in 20 minutes. And you're like, damn it, I just did it. And then, but now you know why, because we're monitoring it. And how many times I'm like, no fluid volume in the last 3 hours. And then they scream at you that are like, well, he goes, don't you know what that means? Because now you know if there's either oliguria or decreased urine volume, what's happening in my kidneys? They're dying. So now you know my kidneys are connected to my liver, my lungs, my everything. That means my patient's dying. So when I start seeing volumes go from 100 ml to 30 to 20 to 10, and then some joker comes up to me and goes, I didn't get any, Dr. Garais, I want to punch him in the face. Like, you know, like, ah, why didn't you tell me? And I'll get all bent out of shape. Or they don't tell me the clarity. How many times there's blood in it? Oh, I forgot to tell you, Dr. Garais, it was pink. Excuse me? And I go, is urine pink, dummy? And then I say choice words. And remember, the personality that you know as your professor is the lighthearted, happy Nelson. You don't know the resident Nelson, the chief senior medical resident Nelson. How many times I should have gotten in trouble for some of the stuff I used to say and call people. But I take this stuff very personally because if, you know, when you're asleep, it messes things up. And also at the end of the day, remember, respondeat superior. You mess up, what happens to you? You get suspended, maybe get fired. I get sued, right? And I get to go to jail. You just get to find another job, right? So it like when the higher you move up the chain, the consequences for poor behavior multiply. And of course, the smell. Of course, it's the typical urine smell, okay? And that's called aromatic, right? Or you could just say normal odor. But if you use the word aromatic, it means that you got some training and you know it. And that just, it's the normal urine smell. Now, what other smells are there? You could have foul, and that smells like rotten fish. And you'll definitely know. So if they have like STD, specifically like gonorrhea or a PID, pelvic inflammatory disease, you can even smell it even with the cap on. It smells like dead, rotten fish. And it smells, yeah, it smells like pretty much like hot garbage. Ugh. Another smell you also might notice is in diabetics is there's a really, really faint acetone smell. It's sweet. It's very, very faint. It's right at the end when you smell urine, and then right at the end, you're like, what's that? Somebody doing their nails? And that's acetone. That's because of the ketone bodies. And we already talked about ketones. That's never a good thing in urine. That means, what do you have tons of in your blood? Ketones. And remember, too much things in your blood become wasteful things. Another thing about clarity is also, the most common for clarity is cloudiness. That means there's way too much fat, right? And if there's way too much fat in my urine, what does that mean? There's way too much fat in the blood, and they should coincide, okay? Microscopic examination, we're looking for crystals. There's crystal formations that could also show you some metabolic problems with your urine. And we're also, of course, looking for any bacteria or anything abnormal in there as well. And last but not least, chemical analysis. We want to make sure that the urine is only slightly acidic. It shouldn't be super acidic or super basic either, unless we're playing with it on purpose. Sometimes I like messing with the acidity in the urine to deal with some of the pharmacology issues, but that's for another class. Again, too much sugar, too much glucose, that means there's way too much sugar in the blood. Electrolyte imbalances, that means there's something going on in the blood. Therefore, the urinalysis has to match the phlebotomy, and how many times junior physicians like, Dr. Garais, I got the urinalysis, and I go, okay, where's the bloods? Oh, you didn't order bloods. And I'm like, did you go to medical school? Just get out of my face. You're stupid.
The CMP.
No, I used to say, I know I'm sharing too much, but this is horrible. I used to go, hey, just kill yourself. Just right now. Just go kill yourself because you're of no use to me. And then they were like, Dr. Garais, don't say that because, upon stressors, there's a high, I shared with you guys, especially in medical school, there's a high rate of suicide and suicide attempts and actually suicide successes.
Really?
Really?
Because you're medical personnel.
I didn't know that.
And also, there's also a high rate of drug addiction.
Yeah.
So, and in my opinion, when I got out, I kind of vowed to train you guys to be better people, because this job makes you, especially, you'll see when you get to nursing, there's kind of like an elitist air when you guys start moving up and less people are in your class. You're survivors, but you become the elite. And then you start treating people like that, like, oh, you're not one of us.
Yeah.
And you could see that definitely in doctors, right? They're just garbage. Some of my colleagues, they're just garbage. Because you got to think about it. Number one, most of them have been rich kids all their life. That's number one. Number two, they've all been smart all their life. So you put that combination together, that's never one for humility. I've
had to work where I'm at. People have always looked down and thought I didn't know stuff when I actually did. I was
when I was a medical assistant and when I was in EMS, they're like, they'll ask you vitals and they're like, you sure? Oh, I'm just gonna take them anyway. Like you're like, well, then why do I work here, man?
My hair.
And they treat you like that. But hang in there, you'll see. There'll be a day where you did it right. And you saved somebody, and you saved somebody's skin, not necessarily the patient, because we don't save anybody. We medical manage people, but you definitely save your colleagues. How many times nursing staff or the clinical staff were like, who put these notes in? And then the lowly MA went, I did. And they're like, oh, they'll never say thank you. They'll never say good job. But if you get one of these from a physician, that means, oh, awesome. Buy yourself a cake. Do something. Do something to celebrate, because there were days when I used to work for my physician that the days that Dr. Abner didn't call me stupid, I go, oh, this is a good day. He only called me stupid 3 times and only a moron twice. So I used to actually put it in my little notebook. Like, oh, cool. He only called me a moron twice. Wow, this is a good day.
At the lab so much where I work at.
Yeah, don't they just crap on each other? Like, and it all flows downward. And if you're the low person on the totem pole, you get all of it.
So annoying.
And you're like, why is that way? Like, and that's why when I matured as a clinician and just dealt with some of the anger issues, I stopped yelling at people. I stopped throwing desks and stopped, during my time, the charts were metal. I used to put dents in them. And to scare people, and
my God.
I was a jerk. If ever you mention my name in New York City circles, especially in Lincoln Hospital, they'll be like, "Oh man, I hate that guy." Because
I bet.
Because I was very smug. Because, like I told you, I'm very disciplined. I don't sleep, and I have my eyes on all the time. So when you don't have your eyes up, I'll say something smug like, it goes, oh, it must be really cool sleeping. It must be really cool to be able to sleep. I'll say something like that, like, oh wow. He goes, isn't it really great that you don't do rounds? Whoa, that's really cool. And the nurses were like,
you're kind of describing my last job at the vet's office.
The nurses were like, F this guy, I'm gonna get him in the parking lot, right? And you're like,
take it outside.
And how many times I got met out in the parking lot, and
really?
I got chewed out by like people like, you can't talk to people that way, and then I do the classic. I'd sit there and go, you done?
Damn.
And he goes, I gotta go, man. And then he goes, and he goes, thanks for all the advice. Because even though all of it was erroneous, and then I'll just get in my car, and the nurses would be yelling at me, or the tech would be yelling at me. Oh, you motherfucker! I'm like, yeah, right. One tech got really mad at me, and her boyfriend came, and I did my classic, because I grew up in the Bronx, and I go, ask your boyfriend, is he bulletproof? Because I really want to know. He goes, and he goes,
my
from
God.
one Marine to an Army guy, is he bulletproof? And the guard's looking at me like, did Dr. Garais just say that to a colleague? And I go, yeah, I thought so. And I go, okay, man of steel, I'm going home now. Right? And then they were like, oh my God, this guy is such.
Oh, I'm like, take a chill pill,
He's
Captain
a
America.
little angry. They used to go, they used to say, which Dr. Garais? My mother worked in the same facility as me. He goes, which Dr. Garais? He goes, the little funny lady in neurology. He goes, or that angry SOB in internal medicine. And then he goes, oh, the angry little man. And I'm like, oh yeah, he goes, that's internal medicine. That's that way, right? But if you've ever, my mother commanded the same authority, but with humor, and being a wise ass, but being a funny wise ass.
Yeah.
And also, and she used to also warn me. She goes, they'll follow you out of fear for only so long. And I'm like, I don't care, like, as long as they follow me, right? And I had that classic knife hand Marine, my way to the highway, or we go out back and we do business, right? And of course, I'm a little guy. I have a Napoleonic complex, definitely. Right? It took me years how to shave that, and also just to treat others with respect. And I told you that they didn't treat me with respect when I was in a lower level. So my attitude was, I'm going to do the same thing when I get to, when I move up.
And that's the hardest part, because I feel like that's how the world works now. It's like, oh, you treat me like crap, then I get to.
Yeah, and then I get to treat other people like you just pass it along.
Mm-hmm. Yeah,
And I know it's a little bit off topic, but because we're looking at other professionals, like what's going on with law enforcement nowadays. There's a lot of good doctors out there, but there's a lot of bad doctors out there. There are a lot of good cops out there. There are a lot of bad ones, and they don't get this training. They don't. No one ever tells them to tone it down, or to tone it down, or get reprimanded by HR. Nowadays, doctors, we can't say squat. You get like half the stuff that I said before, I would have gotten me fired. This was in the late 90s, so
like ethics.
Yeah, and they're high on ethics. Like one last story, and I'll let you guys go. There was a Ford runway model. She was like a teenager, and she won some Ford modeling contract. But her grandmother lived in the Bronx, and she used to come to the ward every day, and she was 5'10", drop dead gorgeous. You know how many doctors, both male and female, hit on her on a daily basis? That could never happen today. But it was every day. I was like, oh, Miss So-and-so, yes, your grandmother's here. Hey, Dr. Garais, well, I had people from other departments like pathology and dermatology. I go, pathology, she's not dead yet. You can't talk to her. Grandmother, leave her the fudge alone, man. And then God. We had surgery coming in, like, did anyone check her feet? And I go, who are you talking about, the grandmother or the granddaughter? I go, get out of here. Right. And then everyone would say stuff like, oh, Nelson's hoarding his patients, doesn't want to. And they were like, ew, this is gross. Right. And the same thing with nurses. I can tell you right now, my first year, I had a staff of like 8 nurses. 3 of them were pregnant and from people other than their boyfriends.
Oh,
staff members.
Jesus Christ.
Yeah. Well, my first boss called my ward the incubator.
Oh,
He's like, how's life in the incubator? And I'm like, he goes, and then he used to giggle. How many of your female staff are pregnant? And I'm like, only 3. And he goes, I heard one more. And I'm like, oh, and then it was my partner. And I'm looking at her like, why'd you get pregnant? And he goes, you can't leave me here alone. And she goes, sorry, next month I go on leave. And you're like, you get so, because you're relatively young and there's stressors. And again, there's good doctors and bad doctors, there's good nurses, bad nurses. Some of this medical personnel, they don't know how not to party. Like, they really work really hard, but come Thursday night or Friday night or Saturday night, they're like, we're at the bar, y'all. And then they'll be at the bar till next shift. And you're like, and they're coming in hungover, which is just another word. It's just another way of saying you're drunk. Do not be that person. Because I've gotten a lot of clinical experience because I'm not the drunk guy. Remember I told you guys, I don't sleep. I'm always diligent. I'm always looking, watching around. There's a reason why I'm in internal medicine. I delivered 68 children in my career. Because other people were not ready to deliver a baby. Either they were high or whatever, or really tired from the night before. And I'm like, and I had to cover, right? And then, or me and other personnel had to cover. So be that person. Be that person who stays awake. Be that person who covers. Be the person who, like, you know, I know it's not the fun person, and it's, but that's the person that we need, especially nowadays. Did you guys hear there's a lot of nurses quitting?
Yeah.
Yeah.
One of them, my daughter quit. My daughter is now no longer a nurse because
Wow.
it was too much. All of this was too much, and they weren't paying her her overtime. And she was like, I don't care. And I go, what happened to the vow you took? She goes, fudge that. And she goes, they're not doing right by me. And she got me, you know, I told you guys that my eldest always gets me with my own words. She says, you told me at a very young age, know your worth. I know my worth, Papa. And goes,
Wow.
I ain't going to get
Of
paid.
course.
That's powerful for her to say
She-
that. I
She
mean,
left in
especially at her
she
age.
left she left her service in late April.
Yeah,
She
in
was in
today's
the
day and age,
hospital
that's
for
a
6
very
weeks straight.
strong statement to make, especially at her age, because not a lot of people know that. They just let people step
Yeah,
all over. and
because
don't
she's like,
stand up for
I know you wouldn't leave your post.
themselves.
And she goes, but I gotta leave. She goes, I gotta make my own decisions. And it was a kind of an argument. And you know, I also tried to even go, what are you, weak? Oh, your generation. And she goes, no, my generation's smarter than yours. And she is.
She kind of
She kind of is. So she's been on vacation the last couple of months, and she started a business with some of her graduate money. And I was afraid that you're gonna lose all the graduate money. He goes, no, I added to it, Papa.
Yeah.
And I'm like, ah, damn
That's
it. Why are my children always proving me wrong with my own words? You know, with my own training.
I
They're
heard a
proving.
joke that says parents always ask, "Oh, why are you like this?" I don't know. Look at the original model.
Oh yeah, yeah.